Gastroenterology, the Philippine Society of Digestive Endoscopy, the Philippine Society of General Internal Medicine, the Philippine College of Occupational Medicine, and the Yellow Warrior Society Philippines. Malusog na atay, masayang buhay.
Dear God, we glorify you for all the blessings you have bestowed upon us. We are truly grateful for them. Thank you for allowing us today to meet and share our knowledge and time with one another virtually. May you send forth your divine wisdom to our speakers as they impart effectively their God-given gift to all of us. May they be blessed as they continue to share their expertise to the people who needs them. Bless the participants as well, so that they would be able to obtain vital information from this activity. May you send forth your Holy Spirit so that after this webinar, we may share what we learned in the spirit of your love and generosity, especially during these trying times. May we be able to bring glory to your word in everything that we do. Amen.
And for the opening remarks, Dr. Suzette Grace Coherman, Treasurer, Hepatology Society of the Philippines.
Hi, greetings. On behalf of the Hepatology Society of the Philippines, it is my great pleasure and honor to welcome everyone to this afternoon's webinar entitled Understanding the Name Changes to Fatty Liver Disease. As you know, fatty liver is a chronic and progressive liver disease that poses a significant challenge to the health and well-being of millions of people. And there have been several nomenclature for fatty liver, such as non-alcoholic fatty liver disease or NAFLD. Then in 2020, the term metabolic dysfunction associated fatty liver disease or MAFLD was proposed to replace the term NAFLD. And more recently, a new term, MASLD or metabolic dysfunction associated steatotic liver disease has been coined. So we hope today's webinar will end the confusion to these name changes. So before I turn you over to our moderator for this afternoon, I would like to thank everyone and express my gratitude for all of you in attending today's webinar. So our moderator for this afternoon is Dr. Ramel Punong-Bayan. So Dr. Ramel is a president of the Philippine Society of General Internal Medicine, and he is a national board of the Philippine College of Occupational Medicine, and he is a co-chair of the Universal Healthcare Committee of the Philippine College of Physicians. Ladies and gentlemen, I call on Dr. Ramel Punong-Bayan.
Hello. Thank you, Dr. Herman, for that very kind introduction. So I'm very excited this afternoon. By the way, we are still in the celebration of the liver cancer and viral hepatitis awareness and prevention month, and we are now at the Fatty Liver Week. So every week we have activities regarding our liver cancer and viral hepatitis awareness and prevention month. And today, as Dr. Herman have said a while ago, we have a very interesting topic kasi ang dami ng nomenclature, ang dami ng pinanggalingan ng term na fatty liver. Iba-ibang specialty, iba-iba yung tawag. So now, we invited the expert, a gastroenterologist, to shed a light kung ano na ba talaga ang latest update regarding the nomenclature of the fatty liver disease. So without further ado, let me have the honor of introducing our expert speaker for this afternoon. He is the first Vice President of the Philippine Society of Gastroenterology, overall Chair of the Philippine Digestive Health Week Joint Annual Convention this year, 2024, Head of the Institute of Digestive and Liver Diseases at the St. Luke's Medical Center, BGC, and the Chief in the Section of Hepatology of the Institute of Digestive and Liver Diseases at the St. Luke's Medical Center, Quezon City. Also a member of the Hepatology Interest Group of the World Gastroenterology Organization. Past President of the Hepatology Society of the Philippines. And personally, I already worked with him being the Scientific Chair of the annual convention of the Philippine College of Physicians. So without any other further ado, help me in welcoming our expert speaker for this afternoon, Dr. Ian Homer Waikua. Dr. Ian, the floor is yours po.
So welcome everyone. First and foremost, like to thank the Hepatology Society of the Philippines, headed by President Dr. Wendell Espinosa, the Hepatology Society of the Philippines Vice President and Chair of the Liver Cancer and Viral Hepatitis Awareness Month, Dr. Angelo Losada, for this wonderful invitation. Today, we embark on a journey to understand the dynamic evolution of terminology in fatty liver disease, from the familiar NAFLD to the transformative shifts towards MAFLD and MASLD, and our exploration delves into the reasons, controversies, and implications surrounding the name changes, and let's unravel the intricacies and significance together. Firstly, we will discuss into the historical evolution of terminology, understanding why these changes occurred. Next, we will examine the alterations in diagnostic criteria that accompany this evolution, exploring how these changes influence disease identification. And lastly, we will analyze the clinical implications of transitioning from NAFLD to MAFLD-MASLD, and our focus will be on how this shift impacts our understanding and management of fatty liver disease, emphasizing accurate diagnosis, improve patient care, and achieving better outcomes. Non-alcoholic fatty liver disease is a leading cause of liver disease worldwide, affecting 1 billion people. Its prevalence varies globally, with the Middle East and the South American reporting the highest rates. Diagnosing non-alcoholic fatty liver disease involves confirming the accumulation of fat in the liver while excluding other potential causes. Notably, with the spectrum of NAFLD, about 20% will progress to non-alcoholic steatohepatitis, a condition that significantly increases the risk of severe complications such as cirrhosis and liver cancer. It's noteworthy that cardiovascular disease stands as the leading cause of death, followed by cancer and liver-related issues in individuals with NAFLD. So this highlights the critical importance of understanding and effectively managing this widespread condition. So let's navigate the intricate landscape of naming controversies in fatty liver disease and evolution of terminology. In 1836, Addison first described a liver condition linked to alcohol use. Over time, pathologists found similar liver issues in diabetics, morbidly obese patients, and heavy drinkers. In 1979, Miller discovered a non-alcoholic liver disease resembling alcohol-induced problems, and Adler and Schaffner noted fatty liver hepatitis and cirrhosis in obese patients. And in 1980, Ludwig reported non-alcoholic steatohepatitis resembling alcohol-related liver disease but without a history of excessive alcohol use. Through several studies, it was evidence that patients with NAFLD also have metabolic abnormalities such as insulin resistance, hyperglycemia, hyperuricemia, hypertriglyceridemia, and hypertension. Despite its significance, NAFLD has faced criticisms for its potential to stigmatize and oversimplify a complex condition. To address this, a consensus of international experts proposed a new name, metabolic dysfunction associated fatty liver disease. This change aims to shift the focus towards metabolic abnormalities and away from potential stigma. In 2020, a significant development occurred with the introduction of the term metabolic associated fatty liver disease. So this change sought to create an inclusive diagnosis that prioritized metabolic factors. However, it came with modification in diagnostic criteria, allowing the coexistence of other liver disease like alcohol-related liver disease and chronic hepatitis B and C. Further evolution in terminology emerged in June 2023 with the proposal of an alternative to NAFLD, the metabolic dysfunction associated steatotic liver disease, or what we call MASLD. So this change involved amending the diagnostic criteria, now requiring at least one of the 5 cardiometabolic risk factors. Additionally, a new category, the metabolic ALD or MET-ALD, was established to permit greater alcohol consumption, distinguishing it from the pure MASLD and alcoholic liver disease, and both names aim to be non-stigmatizing, fostering effective patient identification. So this journey through changing terminology showcases the ongoing efforts to accurately represent the complexities of liver disease and ensure a patient-centered approach. For the NAFLD definition, the definition of non-alcoholic Fatty liver disease requires there is evidence of hepatic steatosis, either imaging or by histology, and there are no causes for secondary hepatic accumulation, such as significant alcohol consumption, the use of steatogenic medications, or hereditary disorders. It was associated with metabolic risk factors such as obesity, diabetes, and dyslipidemia. NAFLD is histologically further categorized into non-alcoholic fatty liver and as well as non-alcoholic steatohepatitis. Is NAFLD the right name and definition? So the terminology non-alcoholic trivializes and stigmatizes the disease. So there is a need to distance the disease from alcohol use. Does not capture the heterogeneity of the patient population with regards to the drivers and disease modifier. So what is the safe limit of alcohol? And it does not define an individual's phenotype with enough precision to develop targeted therapies, hence poor response and trial failure. And NAFLD diagnosis is based on exclusion. There is a need to diagnose using a positive criteria to NAFLD can coexist with other liver disease synergistic on outcomes. And there is a lack of patient awareness, public response, and funding for NAFLD. What should any new definition aim to achieve? First, to improve identification of severe hepatic and extrahepatic disease, allow disease stratification and overcome heterogeneity, thus provides framework for precision medicine, increases this disease awareness and reduces stigma, identifies cases irrespective of the other disease, allowing for identification of coexisting of the disease and potentially accelerates drug development, or at least has no negative impact on ongoing clinical trials and applicable across health system. With our growing knowledge of its causes and increasing prevalence of fatty liver disease, we now need a clear positive criteria for diagnosis. The metabolic dysfunction associated fatty liver disease is a term introduced in the last few years intended for better understanding and classification of fatty liver disease. We are honored to be part of this APASL Guidelines 2020. So the concept emerged from an international group of experts at a consensus conference held in 2020. So the group recognized the need for unifying terminology encompassing the diverse metabolic factors and associated liver disorders commonly observed in patients with fatty liver disease. So this definition stands on its own and does not depend on excluding other liver disease. MAFLD is defined as the presence of hepatic steatosis together with one of or the more of the following. One is overweight or obesity, second type 2 diabetes, and the third is 2 or more other metabolic risk abnormalities. So as a result, some patients who were previously classified as having lean NAFLD may not fulfill the criteria of MAFLD. On the other hand, patients with hepatic steatosis who were previously classified as not having NAFLD due to alcohol consumption, other disease, or secondary causes of fatty liver may nevertheless be diagnosed with MAFLD. So data from population studies suggests that the majority of patients with fatty liver would fulfill the definitions of both NAFLD and MAFLD, but up to 10 to 25% may only meet the criteria of one of the following conditions. So let's explore the intriguing world of fatty liver disease by comparing NAFLD and MAFLD. So firstly, let's look at the similarities. So both NAFLD and MAFLD involve the accumulation of excess fat in the liver, a condition known as steatosis. This commonality forms the basis of their association with the metabolic dysfunction. Now let's delve into the differences. While NAFLD excludes individuals with significant alcohol consumption, MAFLD takes a broader approach, considering metabolic dysfunction as a core element, regardless of the alcohol use. So this shift is crucial for a more inclusive and comprehensive understanding of these conditions. Another noteworthy distinction is the terminology itself. NAFLD focuses on the absence of alcohol, emphasizing what it is not. In contrast, MAFLD adopts a positive approach, highlighting the presence of metabolic dysfunction, providing a clear diagnostic framework. So this comparison underscores the dynamic nature of medical terminologies and the ongoing evolution in response to advancing knowledge. And by understanding both the similarities and the differences, we can navigate these complex conditions more effectively, paving the way for improved patient care. So let's delve into an intriguing analogy that compares changes in the diagnostic criteria and their potential impact. Considering this scenario, if we were raise the cutoff for fasting glucose from 7 to 15 to diagnose diabetes, would indeed identify a group at a much higher risk of diabetic complications. However, the flip side is that we might miss individuals with a fasting glucose between 7 to 15 who could still develop complications. Now, let's draw a parallel to the proposed MAFLD definition. While it effectively identifies a group of patients with fatty liver and metabolic disorders, indicating a higher risk of complications across cardiovascular, metabolic, and liver-related domains, it's crucial to scrutinize another group. What about those with fatty liver who don't meet the metabolic criteria? Are they really truly at a low risk of complications? And in one study, by Kim and colleagues suggests that this specific group might not experience increased overall cardiovascular and cancer mortality. However, more comprehensive data on liver-related outcomes are needed to draw definitive conclusions. So this analogy prompts us to critically evaluate the balance between the sensitivity and the specificity in diagnostic criteria, acknowledging the potential implications for patient outcomes. So what are the arguments in renaming NAFLD to MAFLD? So firstly, there's a crucial discussion on the validity of this transformative process. So while it aims to enhance understanding, there's an inherent risk of confusion that could potentially jeopardize the intended impact on disease awareness and stigma reduction. One significant consideration is the impact of alcohol in the evolving nomenclature. The exclusion or inclusion of alcohol-related liver disease raises questions on about how this decision might shape public perception and understanding. Additionally, there's a notably lack of clarity regarding metabolic dysfunction. It's essential to recognize that other liver disease such as Wilson's disease also have metabolic components, and this raises concerns about the adaptability of the new terminology to accommodate emerging disease phenotype. And finally, this shift has implications for drug and biomarker development. The evolving landscape may pose challenges in standardizing research efforts and develop interventions tailored to the diverse spectrum of the disease. In navigating these intricacies, it's crucial to weigh the potential benefits of the evolving terminologies against the risks and challenges it introduces. Is MAFLD different from NAFLD? So a comprehensive study involving 12,000 plus participants from the NHES3 database between exploring the dynamics between NAFLD and MAFLD. So the study revealed a strong concordance between MAFLD and NAFLD with no major clinical difference except for alcohol-related components in the MAFLD. And over a 27-year follow-up, both cohorts showed similar all-cause and cause-specific mortality rates. Insights into predictive factors highlighted insulin resistance in NAFLD, predicting liver mortality, while in MAFLD, alcohol-associated liver disease emerged as a key predictor. And these findings underscore the distinction between NAFLD and MAFLD, emphasizing the importance of considering metabolic and alcohol-related factors in understanding the disease outcome. And there's a robust evidence for validity and superiority of MAFLD versus NAFLD. So the practical implications of MAFLD definition in identifying patients with fatty liver disease. So the MAFLD definition proves to be very practical, effectively identifying individuals at a high risk of disease progression, exploring the MAFLD-only group reveals a strong association with fibrosis as well as higher liver stiffness, regardless of the demographics and the lifestyle factors. And notably, MAFLD-only category exhibits the highest risk for fibrosis, while the NAFLD-only group carries the lowest risk. Delving into the MAFLD patients with HCC, we uncover worse liver function, severe portal hypertension, and a tendency towards a less curative therapy. In addition, MAFLD takes the lead in predicting the onset of chronic kidney disease, outperforming NAFLD. It is not only associated with a greater impairment of the lung function, but also significantly linked to colorectal adenoma and cognitive impairment. And in terms of mortality, MAFLD are showing the highest incidence of the all-cause mortality and cardiovascular disease, and MAFLD proves superior in identifying advanced steatosis, cirrhosis, and metabolic dysfunction in patients with chronic hepatitis B and C. And lastly, MAFLD heightens the risk of adverse outcomes and mortality in patients with chronic hepatitis B. And these findings underscore the comprehensive impact of MAFLD across various health domains. And a significant majority became more familiar with fatty liver following the name change to MAFLD, cutting across diverse cultural backgrounds and health system. And this positive shift has been endorsed by more than 164 stakeholders worldwide, and the MAFLD definition plays a crucial role in guiding the subtyping of patients with fatty liver disease and effectively identifies individuals who will benefit from genetics testing. And MAFLD serves as a guide for disease stratification, overcoming heterogeneity, and providing a framework for precision medicine. And this approach opens avenues for novel clinical trials, shaping the future of disease management. So the transition to MAFLD is not just a change in the name, it's a transformative journey towards improved awareness, reduced stigma, and enhanced precision in healthcare. So in 2023, the metabolic dysfunction associated steatotic liver disease was introduced. 3 pan-national liver associations were involved in a modified Delphi process to develop a group consensus using literature review and opinions from experts and patient advocates. So this novel term not only acknowledged the metabolic factor in fatty liver disease, but also strives to eliminate the stigma around the disease. And importantly, MASLD recognizes the overlap with alcoholic liver disease, providing a comprehensive and inclusive framework for diagnosis, research, and clinical management. MASLD diagnostic criteria are straightforward. In the presence of hepatic steatosis, the identification of any cardiometabolic risk factor leads to a diagnosis of MASLD, unless other causes of steatosis are identified, indicating a combination etiology. For alcohol-related steatosis, the term MET ALD or ALD is used based on the extent of alcohol intake. In the absence of overt cardiovascular criteria, exclusion of other etiologies is necessary, leading to the diagnosis of cryptogenic steatotic liver disease. However, depending on the clinical judgment, it can also be considered a possible muscle, emphasizing the need for periodic assessment on a case-to-case basis. Steatotic liver disease diagnosed either histology or imaging encompasses the various potential causes. One significant advancement in the nomenclature is the introduction of muscle, as I mentioned, and person with muscle exhibiting steatohepatitis are designated as metabolic dysfunction associated steatohepatitis or MASH. So in cases where alcohol contributes, it's termed metabolic ALD, emphasizing a continuum wherein the impact of muscle D and the alcohol liver disease varies to align with the current literature. Specific limits for weekly and daily alcohol consumption has been set, recognizing the varied impact on individuals, where weekly alcohol intake is less than 140 for women and less than 210 for men, or a daily alcohol intake of 20 grams for women and 30 grams for men. According to the current literature, the steatosis is thought to be mainly from metabolic dysfunction. On the other end of the spectrum of the alcohol intake, where weekly alcohol intake is more than 350 and 420 for women and men, or a daily alcohol intake more than 50 to 60 for women and men, much of the steatosis is likely to be from the excessive alcohol. And the other causes of steatotic liver disease, each with distinct pathophysiology, are considered separately in clinical practice. Importantly, must acknowledge the potential coexistence of multiple etiologies of steatosis in cases of uncertainty where metabolic dysfunction is strongly suspected despite the absence of cardiometabolic risk factors. It may be early muscle prompting additional testing. Those with no identifiable cause, categorized as cryptogenic steatotic liver disease, might see reclassification pending advancement in disease pathology understanding. The affirmative diagnosis also allows for the coexistence of other disease with muscle D, such as muscle D plus autoimmune hepatitis or viral hepatitis. So this marks a significant step forward in our ability to precisely diagnose and manage a spectrum of liver disease. So for the metabolic dysfunction associated with steatotic liver disease or MASLD is an affirmative set of diagnostic criteria uh, very crucial in advancing our understanding and management of liver disease. So these criteria must be simple, readily available, and easily measurable, ensuring near universal agreement on the side of inclusivity. So this approach minimizes patients' heterogeneity and remains adaptable to future insights. And aligning diagnostic criteria with established cardiometabolic risk factors as seen in other metabolic health disease provides a solid foundation. So this is not only simplifying the diagnostic process, but also enhance our ability to identify and address liver disorders effectively as we navigate into the evolving landscape of liver disease. So this criteria serves as a crucial guide in improving patient outcome. So it's essential to discuss the similarities and differences between MAFLD and MASLD. For the similarities, both MAFLD and MASLD underscore the strong association between metabolic dysfunction and fatty liver disease. So they prioritize addressing the underlying metabolic risk factors for a comprehensive approach to diagnosis and management. So the diagnostic criteria for both conditions involve recognizing the presence of hepatic steatosis in conjunction with the cardiometabolic risk factors, providing a common ground for disease identification. And on the other hand, with regards to their differences, while both terms acknowledge the metabolic aspect, the inclusion of steatohepatitis in muscle de-emphasizes the histologic aspects, distinguishing it from the broader fatty liver approach in MAFLD. MASLD introduces the category of MET ALD to account for the alcohol consumption, recognizing the coexistence of metabolic dysfunction and alcoholic liver disease issues, and MAFLD, on the other hand, maintains a focus on metabolic factors. The approach to patient categorization differs, with MAFLD allowing for more flexibility in considering various etiologies, including alcohol, while MASLD seeks a more specific identification through cardiometabolic risk factors. So navigating the nuances and distinction between MAFLD and MASLD provides a comprehensive view, guiding the clinicians and researchers in addressing the complexities of metabolic associated liver disease effectively. And there's one study wherein both NAFLD and MASLD exhibit substantial similarities, especially when analyzed in the tertiary centers and scrutinized through large-scale database like the NS. So this underscored the overlap in patient presentations and characteristics. So despite their conceptual differences, mortality rates in MASLD and NAFLD are notably close. However, it's observed that MASLD may have a slightly higher mortality rate, indicating the distinctions. And MASLD might exhibit limitations in specific demographics, particularly in cases involving young individuals or those presenting in the primary care setting. So this suggests that MASLD might not capture the certain conditions or could miss cases in specific patient population. And in the broader context, the nomenclature shift from NAFLD to MASLD might not significantly alter the evidence generated for the vast majority of patients, and the fundamental clinical aspects and outcomes remain largely consistent despite the change in the terminology. And how about analyzing controversies in the nomenclature? So the term fatty liver is not stigmatizing, as suggested by the others in the field and the patients group. MAFLD excludes alcohol from the diagnostic criteria, so it defines the liver disease based on the metabolic dysregulation unrelated to alcohol consumption or viral hepatitis, and avoids the need for separate disease names in cases of concomitant conditions. MASLD labels significant alcohol consumption as a different disease, which is the MET-ALD, and the MET-ALD is the coexistence of two diseases in the same person, and suggests defining each liver disease on its merit rather than the new terms. And then identifying alcohol as a special case lacks precision. Studies have shown that the uncertainty about alcohol threshold leading to liver damage, and even in high alcohol consumption, it doesn't exclude the metabolic dysfunction's contribution to the disease trajectory. And MAFLD is a clinical diagnosis, while steatohepatitis is a histological diagnosis. So the histofeatures remains unchanged. It doesn't diminish the disease activity and the fibrosis stage. And MASLD is criticized for trying to encompass diverse conditions, being a consensus-driven approach. Over 90% of individuals with cirrhotic liver disease may be overclassified, with MASLD potentially missing a specific liver disease. In the discourse surrounding liver disease, particularly the transition from NAFLD to the newer nomenclatures, like the MASLD, the certain aspects warrant critical examination. So one of the notably challenges associated with MASLD lies in its lack of granularity and specificity, both in the general population and the post-transplant scenario. So this raises concerns about its precision in accurately identifying and characterizing the diverse spectrum of liver conditions. And comparative analysis revealed that MAFLD demonstrates superiority in identifying significant fibrosis when juxtaposed with muscle D. So this highlights potential limitations within the muscle criteria, emphasizing the need for a more discerning approach in clinical diagnosis. And within the landscape of liver disease definition, MAFLD stands out as the only definition capable of maintaining an optimal balance between sensitivity and specificity. So these characteristics aligns with the meticulous process of selecting an optimal cutoff point on a receiver operating characteristic curve for diagnostic biomarkers. So this finding is expected to have a significant implications for health policy and cost-effective analysis. So in this visual representation, we dissect the landscape of liver disease, emphasizing the key commonalities and distinctions among NAFLD, MAFLD, and MASLD. So all three conditions share a fundamental characteristic, the accumulation of fat in the liver. So this commonality scores the broader theme of hepatic lipid infiltration. NAFLD is specifically characterized by the absence of significant alcohol intake. In contrast, both MAFLD and MASLD are inclusive terminologies acknowledging a spectrum of patients irrespective of the alcohol consumption. And unlike NAFLD, which does not explicitly consider BMI, so both MAFLD and MASLD adopt a more comprehensive approach by encompassing patients across different BMI ranges. So this broader inclusivity aims to capture the diverse manifestations of this liver condition. As we navigate this visual representation, it becomes evident that the shift from NAFLD to MAFLD signifies a move towards a more encompassing and refined understanding of liver disease, capturing a diverse patient population and accounting for various influencing factors. So in conclusion, the transformative shift from NAFLD to MAFLD-MASLD is a significant conceptual change in our comprehension of fatty liver disease. This evolution sparks an ongoing debate, serving as a reminder of the dynamic nature of medical terminology. So the call is clear to unify under the new terminology, acknowledging the intricacies of these conditions. MAFLD not only redefines the nomenclature, but more importantly, emphasizes a robust connection between metabolic dysfunction and fatty liver disease. So this paradigm shift underscores the imperative to address the underlying metabolic risk factors, steering the narrative towards a holistic understanding of these complex conditions. The introduction of this new terminology is not merely a change in labels, it represents a strategic move towards a more refined understanding of fatty liver disease. The primary objective is to enhance disease recognition, paving the way for more accurate diagnosis. Beyond that, the emphasis on risk stratification becomes important, steering us towards personalized approach tailored to improve patient outcomes, and the ultimate goal transcends terminology. It's about elevating patient care standards, driving disease awareness, and fostering collaborative efforts in research. Thank you very much for listening.
So, thank you very much, Dr. Ian. Grabe. Sobrang linaw ng ating lecture for this afternoon. Para akong nag-review, sir. Na-update ako, tapos nag-review ako. So, sobrang as in, crystal clear. Although, sir, kasi most of our audience ngayon in the session are primary care providers, na mga frontliners. Ano ba, sir? Kasi malaking factor is the alcohol exposure. Is there a blood test or a single test na para kasi minsan, sir, mahirap i-quantify lalo na pag hindi naman specialist, no? Hindi nila ma-quantify yung alcohol exposure. Is there a test na marirecommend kayo, sir, sa blood or anything na parang magkakaroon sila ng clue na significant yung exposure nung
Ng
work
patient.
patient?
Okay.
Yeah.
Thank you very much, everyone, for attending this webinar. So, with regards to the safety limits of alcohol, there's a recent study in Korea wherein they see patients with fatty liver and with low fibrosis, and they categorize the patient whether the patient is drinking alcohol or light drinker, moderate, and severe, yung heavy drinker. So, what happened after like looking at like more than 10 years of follow-up, so most patient, even though they drink small amounts of alcohol, they still develop liver fibrosis. So the question now is, what is the safe limits of alcohol? So for now, with this particular study, as long as you're not drinking alcohol, so it's safe. And then I think wala na talagang safety limits of alcohol. It all depends on the patient's how they metabolize the alcohol. But if you look at the definition before the NAFLD wherein they limit the amount of alcohol at least 20 grams per day for female and 30 grams for male. But with regards to the definition, when with the MET ALD, no, with the new terminology, so they set the limit, no. So for alcohol limit of like 30 to 30 grams for female and 40 grams of alcohol for male, no, daily. So this is considered as a alcohol liver disease. But for severe type, they need to take at least 50 grams of alcohol for female and 60 grams of alcohol sa male. So that considered a ALD predominant. So with regards to the terminology sa muscle D, so may in between sila o may. So yung in between nila, sinasabi nila na may fatty liver at the same time metabolic syndrome, and then may significant alcohol intake. So
Actually,
yes.
sige sir. Go ahead, sir.
Yeah, so how do we determine ilang grams ba yung mga drinks natin? So we usually around 10 to 15 grams kasi yung a can of beer and a glass of wine, and then yung shot ng hard drinks. So that's considered around 10 to 12 grams of alcohol.
Ayun. Thank you, sir. Ha. May, sobrang daming information yan for our primary care providers. Actually, sir, in relation to that, tawag dito, dahil bago nga itong mga terminologies na to, di ba? Just recent lang to, mga 2020, 2023. Sir, is there already a number, like epidemiological numbers? Ilan ba yung nag-overlap na meron na silang metabolic, meron pa silang alcohol, meron pa silang alcohol exposure, tapos meron pa siyang parang yung symptoms ng metabolic liver disease. May
Okay.
gaano na ba kadami sa population natin, particularly in the Philippines?
So, okay, so if you look at epidemiologic study, no, so with regards to the definition of muffled D and muscle D, so they did not include yung alcohol intake sa inclusion criteria. So both terminologies, they look alcohol as a parang dual etiology in patients who has fatty liver, metabolic syndrome, and also drinking alcohol. So, ang pinag-debate kasi nila is yung walang inclusion ng alcohol intake sa muffle D. But for muscle D, what they did is just they coined another word na met alcohol liver disease. So it created a confusion kasi ang dami ng mga names ng fatty liver, di ba?
Ayun. Ayun sir. Actually sir, tama ba yung intindi ko? If parang ibabalik ko lang. Pwede namang gamitin pa rin yung NAFLD kasi may criteria naman eh. Di ba may qualifier naman. NAFLD, MAFLD, at saka yung MASLD. So pwede naman namin sir gamitin yan. Provided na tulad ng diniscuss nyo kanina na may qualifiers tayo. Tama po ba?
Yeah, so with the transformative change from NAFLD to MAFLD and MASLD, so we no longer use the term non-alcoholic fatty liver disease because this is a diagnosis of exclusion. So ang recommendation is we have to do the metabolic associated fatty liver disease because they look into like three, di ba may three criteria siya. So patient with fatty liver, those who are overweight, obese, and then those with diabetes, pasok na siya sa criteria. And then for those normal and lean individuals, as long as they meet the 2 out of 5 criteria for metabolic syndrome, so they are now termed as metabolic associated fatty liver disease. So the only reason why they changed the nomenclature is one, because they say that fatty liver is stigmatizing. But in fact, when we talk to patient and tell them, oh, meron kang muscle D. So ano yun, doc? So we have metabolic associated steatotic liver disease. So syempre, if we translate that in the local dialect, so kwan pa rin siya. At the same time, sasabihin mo may fatty liver ka pa rin. So I think the fatty liver na term is not stigmatizing as, kung obesity na tinatawag. And then, ang pinaka-issue talaga with the new terminology muscle D is the criteria. So, ang tendency is they will overdiagnose patient kasi the criteria for muscle D is you need to meet at least 1 out of 5. So if you look at the criteria, nandun naman yung diabetes, yung overweight and obesity, but the only thing is they add yung blood pressure, the levels of the HDL, and yung sa isa pang criteria. So there's one study from India wherein they look at the muscle D definition. So what happened is na-overdiagnose talaga at least mga 70%. So the person who did not fall under obesity, overweight, or diabetes, tinatawag natin na dysmetabolic. So ang tendency is we tend to overdiagnose with muscle D, and then because of the lack of the specificity. So parang instead of looking at the true positive, so naging mas madaming false positive.
Actually, with that, sir, siguro mas maganda ma-play over and over tong lecture mo in different fora, ano? Kasi yun nga, yung overdiagnosis, maraming effect yan May socio-economic, may hindi lang sa health system So, yun nga, siguro, kasi this is just a single lecture, probably we can echo, lalo na po sa amin, sir, yung mga primary care providers.
So, Dr. Punong Bayan, so
Yes.
ito lang talaga. So, with the naming controversy, the good thing is it created a lot of controversy, and then it plays yung fatty liver in the the realm of the patient na awareness, also the disease awareness. So that's a good thing with the naming controversy. And then ang importante lang is we have to educate our colleagues with regards to the name change kasi may impact talaga siya. So aside from the naming, the renaming of the NAFLD to MAFLD, so ang pinaka-importante is it emphasizes a robust connection between the metabolic dysfunction or metabolic syndrome and the fatty liver disease. Yun talaga importante, because once we diagnose this patient, we can make a accurate diagnosis, and also we have to stratify this patient accordingly. So in the end, we will provide a better patient outcomes as well as improve in the patient care.
Tama, sir. Actually, sir, with my limited year of practice, natatandaan ko yung fatty liver. Pag tinatanong, anong gagawin namin dito? Pahinga lang yan, candy lang. Alam mo yung parang ano lang siya, dinidedma lang siya. Hindi naman sakit yan. So, lalo na yung ibang specialty, sobrang nakita ko, sir, yung transition na naging metabolic risk factor yung fatty liver. Tsaka ito nga, yung better and more accurate nomenclature which in the end, mas maganda siguro outcome ng patient care. Yung nga sabi mo, mababawasan natin yung overdiagnosis. Ano, sir? Sir, meron lang ako isang very, very quick lang na question na medyo katabi lang din itong topic natin. Kasi sir, sa social media, ang daming nakikitang mga detox about fatty liver. Can you comment on that? Kasi di ba sobrang sikat na sikat tong mga detox na to, lalo na nasa primary care tong mga audience natin, nasa municipal health. Ang dami kasing ganyan sa social media ngayon na itong i-drink mo na to, gamot to sa fatty liver. So, I know it's a little bit out of topic, kaya lang I'm just kinuha ko na yung opportunity dahil nandito ka, sir. Can you comment on that, yung mga
Okay.
supplements na yan?
So So we all know that the metabolic associated fatty liver disease, it has a metabolic connection, di ba? The metabolic dysfunction. So ang pinaka cornerstone in treating this patient is lifestyle change. So we encourage our patient to lose weight, and there's studies that if you lose weight through diet and exercise, it can improve your fatty liver, as well as most importantly the fibrosis stage, no? So aside from weight loss, if you have metabolic syndrome, we need to give them antihypertensives for hypertension, and also we need medications if you have diabetes or cholesterol issues, and some uric acid and blood pressure. So aside from that, at this point, there's no FDA approved medications for fatty liver. So there's evidence there that vitamin E can help, but the rest of the hepatoprotectants, they did not reach the level wherein we can recommend them for use in these particular patients.
Ayun, thank you, sir. Talagang ano kailangan ko itanong kasi this is really a very large controversy aside from the nomenclature. By the way, sir, at ala na yata tayong question and we really
There's
thank you.
another question, Ome, from Dr. Payawal. So
Okay.
she asked about the role of the SGPT
Ako'y, yeah. What is
in
the role of the
diagnosing.
SGPT in the roadmap? Yun pala, sir, meron pala dito sa
Okay.
chat. Oo.
Okay, so if you look at the present roadmap, no, so once we identify this patient, it's very important. Now we have to rule out the other causes of liver disease, since we are hyperendemic for hepatitis B. So, and second, we don't use SGPT anymore as to monitor whether this patient improve from the treatment from fatty liver, because studies have shown even though in patients with normal SGPT, some of them will have advanced fibrosis or liver cirrhosis. So hindi talaga siya yung absolute na gagamitin natin na indications for treatment or for monitoring or for diagnosis. So importante is once you see a patient with metabolic fatty liver disease, we have to stratify this patient whether they're low risk or high risk to develop liver cirrhosis. So ang next na gagawin natin is we have this online calculator wherein we check the NAFLD fibrosis index. So it's easy to use. We use the common parameters such as the SGPT, SGOT, the weight, the height, and also the platelets of the patient. So we can stratify them whether there's low risk to develop advanced fibrosis and cirrhosis. And then for patients, we have a higher NAFLD fibrosis score. We refer them to the specialist if we're thinking that this patient has advanced fibrosis and liver cirrhosis.
Ayun, thank you Dr. Diana for bringing that up. So maliwanag po yan guys hindi talaga direct measures ng progression ng liver disease yung SGPT.
And most importantly, we don't utilize the SGPT as a surrogate marker of liver disease in
Yes.
diagnosing liver disease.
Okay. With that, sir, thank you so much. Sobrang dami ko na namang natutunan this afternoon. Sabi ko nga dun sa mga colleagues ko, sobrang excited ako for this topic this afternoon. So, with that, makita naman natin na the changing in the nomenclature is more of erasing the stigma of the fatty liver diagnosis. Also, going to a more accurate and more patient-centered approach to managing this group of diseases. So with that, thank you very much, everyone. Dr. Ian, thank you so much for your time and your expertise. Dr. Diana, thank you for that. And lagi natin tatandaan, ang malusog na atay ay masayang buhay. Thank you everyone. Thank you po sa lahat ng umattend. Thank you so much.
Thank you. Thank you very much.